Hey y'all, welcome to another episode of The Last Zebra. I'm your host, Ugo Ezema. As always, please don't forget to like, subscribe, and share. And today I have the honor of my next guest, Krystal Henry. Welcome to the show.
Hi, thank you for having me.
Absolutely. Really happy for you to take the time to be with us today. Tell us a little bit about yourself.
So I am a nurse practitioner. So I guess I'll start from the beginning, my professional journey. Since I was very young and can remember anything about what you want to do when you grow up, that's the question you get. I've always wanted to be a nurse. It was the only profession that I ever had a desire to work in. I genuinely have a strong desire to help people, take care of people, and care for people. And so that is just the part of me that's nurturing, that wanted to become a nurse. And so I got a bachelor's from Dillard University here in New Orleans. And I always say when I mention my alma mater that Dillard's nursing program was founded in 1942, and it was the first baccalaureate nursing program in the state. And so it's a very big deal to graduate from Dillard University in nursing, a lot of history there. I worked after I graduated from Dillard at Touro as a staff nurse, med-surg, telemetry, orthopedics, a variety of things. And what I found when I was doing staff nursing was that the same patients would chronically come back. Readmission rates. And so they would come back and you're admitting them and you're asking them, what happened? I didn't do this, didn't do that. And it all boiled down to they just didn't have buy-in about their disease, the medications. They just weren't adherent to the plan. And so I said, I'm going to go back and do something so that I can educate and make a change. And so I went back to become a nurse practitioner from Loyola here in New Orleans. And I have been doing that since 2002. A family nurse practitioner. Since then, I've picked up a desire for education. I went to Vanderbilt, got a doctorate. And so now I not only practice as an NP, I educate future nurses, future nurse practitioners. So a lot of different things that I do. My hands are full. That's professionally. Personally, I am a daughter, a sister, a wife, a mother. And so I have a husband who's a New Orleans police officer. We have 3 children, 1 bonus daughter who has my exact name, Krystal Renee. That's just like supposed to be, right?
Yeah.
And then I have Nicholas and Madison.
That's amazing.
Yeah.
That's well said and very succinct. Dillard, when I was applying for schools, I grew up between Nigeria and Jamaica. Okay. When I was applying for schools, I came to New Orleans in 2005, right before Katrina. And Dillard was on my list of places to. I think it was them, Nicholls State, Xavier, and I want to say Loyola. Nicholls State being the one that gave me the best scholarship for me to go. So I ended up going to Nicholls.
Wonderful.
And after that, I hadn't really thought about Dillard for a very long time until relatively recently. We have some friends that have some affiliations with them. And I did not know so much about Dillard. And up to this very moment, I did not know that the nursing school was the very first in the state.
Yeah, baccalaureate program.
The first baccalaureate program in the state. You mentioned the history of that program. What was it like going through that? Because Dillard is a HBCU, is it? It
is. It is an HBCU, and so it was wonderful. The time so I went to Dillard on a 4-year academic scholarship, so I didn't have to pay. And they called it a university scholar back then. I don't know what it was, but the structure of the nursing program when I was there, I went from 93 to 97, it really wasn't structured for you to finish in 4 years. It was more like a 5-year program unless you went year-round because you had prereqs your first year. And so your first semester of freshman year was 21 hours. The second semester, the spring semester, was 21 hours. And then you got into the nursing program and did your nursing courses in addition to your core curricular courses. And you had to do clinical. So it was a lot of stuff to do in 4 years. But you have to know my mother to know. She was like, they're paying for 4 years, you're getting out in 4 years, so make it happen. So, we're registering, and my sister and I are probably the only people who went to college registration day with our mother. She was like, I'm coming. And so she comes and, they're saying 21 hours is a lot. And she was like, you took 7 courses in high school, you can take 7 in college. What's different? And so I got out in 4 years, but it was a wonderful time because we were there with everyone else in the city who chose not to leave to go away for school. And so I could drive to school from home, go back home. I had friends who were here from other schools, from my school. One of my best friends went from high school with me to Dillard, and we went to Loyola together. And so we have remained in touch. But it was just wonderful. Enough independence that you needed, but you still had the comfort of going home without any responsibility except for school. So you could focus and do what needed to be done. The nursing program, it was a lot because nursing is not the easiest program to complete.
Yeah,
I'm sure you've heard that.
Yeah, absolutely. Especially fresh out of high school.
Fresh out of high school. And so I'm a December birthday, but I started school early because mama was like, what are you going to do? So I was very young finishing nursing school. And nursing is challenging. I don't say that lightly. I mean, I know medical school is challenging too, but in nursing school, we not only have to learn the disease, the medicines, the treatments, we have to know what the medicines are going to do, the side effects, how to manage the person. It's like a holistic approach to managing, and you have to learn all of that in essentially 3 years because the nursing school is 3. Your first year is prereqs.
Right.
And so you're getting a lot of information thrown at you, terminology you have not heard. It's a lot of different things. And so your brain is trying to process it. It works, if you can focus on it and get it done. But, so it worked.
Not to mention the nuances of being a nurse that are unique to that profession.
It's an art,
yeah,
right? It is truly to be a really good nurse. So when I worked at Turo, it was 12-hour shifts back then. Patients, as I understand it, are sicker these days. But when I was a nurse at Turo, our ratios were 7-1.
Wow.
Right. You see, you say that to people now and there's a 7, but that's what they were. Patients are a lot sicker these days, but we would have 7-1 on a standard med-surg floor. And if you were a really good nurse, it was a totally draining 12 hours. You really don't get to sit down because if you're intentional about your nursing and you want the best outcomes for your patients, you're tending to them. You're making sure their family is aware of everything that's going on. You're looking for your doctors to round with them. At least I was, because I want to know what you are writing so I can be on top of it, so we can get these things done. So, it was very, very difficult. And I used to work 3 12s in a row. And so I had a great schedule, Tuesday, Wednesday, Thursday. Come Thursday, I am exhausted.
Right.
If I have the same patients, it was not so difficult. But if I had a different patient because someone got discharged, you're learning them again. Learning it was a lot of work. And then you not only do your nursing work, you have to help your nursing assistants because if you don't help them, guess what? They won't help you back.
Right.
And so you don't ever really just sit down and cross your legs. If you're sitting down, you're missing something. Somebody needs to be bathed. You need to help, right? That's what it's a team job.
Mm-hmm. How long were you the floor nurse then? How long was that before you went to
So let me tell you something about floor nursing. This is so, when I was at Loyola, one of my professors, she said, so we say that all the time, floor, I'm a floor nurse. And she was like, don't say a floor nurse. What's lower than the floor? She said, you're a unit nurse. You're a staff nurse. So I just, she would say, she just always would tell us that. So now I say unit or staff nurse, but I was a staff nurse for 5 or 6 years. I finished in 97, and then I finished nursing school in 97, passed boards in 97, and I worked as a staff nurse at Turo until 2002 when I finished from Loyola. So I was enrolled at Loyola part-time while I was still working at Turo. I went from day shift. I would work day shift before I went to school. Then when I went back to school, I kind of pivoted to night shift because I needed my days for my clinical.
How long is the NP program?
So when I went to Loyola, I was the 3rd NP class at Loyola University. And so that was Loyola New Orleans. And so that is when nursing school was fully face-to-face, synchronous learning on campus. There was no online. So we went to campus at Loyola. It was a 3-year part-time program, 2-year full-time.
Wow.
And I went part-time. And so finished in May of 2002 and transitioned from there after passing my certification exams. I moved to Memphis, Tennessee, and I worked in a gynecologic practice because that was the only job I can get. This was, people have opinions about NPs, and what the role is. What are you trying to do? You should go to medical school. A lot of different thoughts about it. And I always say, we're not NPs because we couldn't be MDs. We genuinely wanted to be nurses. It's a different
calling.
Right. It's a different calling, a different approach to patient-centered care, right? Everybody gives patient-centered care, but the approach that I feel like MPs bring is a little bit different from what physicians bring. And look, there are some physicians who are very relatable and easy, but where they are busier and more impatient, we are equally as busy. Don't get me wrong. My schedule holds 30 slots, but I just kind of figure out a way to meet patients where they are, which is sometimes looked upon as the NP might not know what they're doing, but we're relationship building. We're using motivational interviewing techniques to try to get buy-in from the patient to do the treatment that we want them to do, right? We know what the evidence says. Mm-hmm. We know what we're supposed to do. But if you just say, okay, you have high blood pressure, here are 2 prescriptions. Mm-hmm. They come back in 2 weeks, the pressure's still high. What happened? Well, I didn't take it. Probably because they never truly believed, or their perceptions from outside influences led them to feel like that medicine is not good for you because the social media group said if you take it, your lips will swell. Wow. Or, the things that people come back. And so I spent a lot of time with patients on the first visit, the second visit, just relationship building. We identify the problems. I let you know what needs to be done. But I want to know how do you feel about it? I genuinely am concerned about how you feel about it, because that is the only way we're going to get some positive change and get you to adhere to the plan that I have, is you have to have buy-in. You have to perceive there is some benefit to the health promoting behavior I'm selling. So I don't even know why I'm on this tangent. What were we talking about?
That's what we're talking about.
Okay.
We're talking about how do you think is the best, what do you think is the best way to elicit that buy-in? Because it can be very challenging.
It's very challenging. Yeah. And so one of the things that nursing does, and full disclosure, my sister is a physician. She is a gynecologist in Charlotte. And so I think one of the things that nursing brings to the table in the NP role is that in nursing programs, you kind of build your practice around a theoretical framework. Right? I'm not sure if that's like that in medicine.
Tell me what you mean.
So a lot of our earlier core courses are about the nursing theorist, their models, and you do a lot of research on these models, and you identify a model that aligns with who you are and how you want to practice as a nurse. And so I align myself with the health belief model. That is the framework for my practice, right? And so that model is it's been so long since school, but it was, I think, created by social psychologists. It's probably really a social model, but this model has as its core that people engage or choose to not engage in health promoting behaviors based on their perceptions, right? Their beliefs about the disease, barriers, their perceived benefits, their own self-efficacy. And so that is the first thing you have to do, is identify what they believe. I could tell you have high blood pressure because the numbers say this, but what does that mean to you? Or I can tell you have diabetes and you shouldn't do this, this, or this, but how do you feel about that? Because we have to remember that they have outside influences that are not working against us as the professionals, but that are also guiding and influencing their beliefs and perceptions. And so I always try to relate to them and get there, because I look at it like this. If you come to the office and you sign in and you get in the room, you want to get well. There's something brought you here. That is the stimulus, right? You want something brought you here. Yeah. So I'm not going to bang you over the head with 10 prescriptions, right? We're going to build a relationship, a good rapport. I'm going to trust you. You're going to trust me. And we're going to get into some shared decision making about the best decisions to improve your health.
I think shared decision making is definitely something that I try to employ myself. The challenge with that can be in the constraints of one visit.
That's it.
How are you able to? Well, I mean, I guess that's part of the longitudinal relationship building. So, trying to be a little bit more present with each of your appointments, each of your clinic visits with the patient, and navigating that relationship in such a way that you are engaging into that the health belief system. Then,
yeah.
And that takes time.
It takes time. And so I say that to say that sometimes you may have, because, I work in a community health center. And so we have 15-minute slots all day. Okay. And so that is not a lot of time because they check in. That's 5 minutes gone. The triage process is another 5 minutes.
Right.
So technically I have 5 minutes
Right.
to get everything I have to say. And I'm a talker in the room. And so I say that for every patient that takes me 30 or 40 minutes, there's 2 that take 5. I just need a TB test. So for some, or people no show. So it balances out. But what will happen is at the first visit is where I do most of my engaging and talking. Tell me about your family. Oh, you have kids? Let me see them. Let's build a relationship here because I am genuinely invested in your health, which is why I'm here, because healthy people build healthy communities. And I want you to get out and spread the good word about, look what happened when I went here today. And so just to motivate them, half of it's just that people believe that nobody cares about them. They've been talked at instead of talked to. Nobody's ever asked what they think about the medicines that they are prescribing. And so sometimes, this is where I was going, sometimes it'll look like if I see a person and I identify a bunch of things, I mean, I know you need a statin if you have diabetes, but I'm not going to give you 20 prescriptions today because you're never coming back. And so if you don't see me for your 2-week follow-up and you see one of my counterparts, you didn't give them a statin. Well, it is about slow and steady wins the race sometimes, right? And so I know what needs to be done, but I'm trying to get them to understand and get some push and pull so that we can get to the end point healthy all the same. Now, certain things, there's no compromise.
Right.
You need this today, we have to do it today. Now, you can make a choice and say, I'm not doing it. But I have delivered the message to you. I really want you to do it. I'm not big on, documenting advised except risk. That is just a cover your type thing. I am genuinely invested in really trying to get you to cross the street to my side to improve your health. I want you to value your own life as much as I value it. I tell my patients all the time, I came today for you. I came today for you. You're on my schedule. I came today.
Yeah.
So you are important to me. So, I just try to get them to understand that they have a life that's worth living. And you want to live it healthy and functional, or you want to live it with the cane? It's just trying to get them, and you meet people where they are. And so some people really like that.
Right.
Some people come in the room on the first visit, and I am Krystal Howard, nurse practitioner. I wanted a doctor, and that is your right. Let's go to the front and get you with the doctor you would like to see. It's totally fine. Yeah. And then some people are like, oh, it's fine. It's just, and I think that is because there are so many different opinions about what is the role and you're trying to do this. Everybody has their own space, right? And so sometimes my collaborator will have patients who he will see, who come to see me, who just want a little bit more discussion and time, which is fine.
Right.
So we can work together. If you have a chronic diabetic who you cannot get to goal, send them over. I'm going to wear them out. They're going to get to goal, though. So it's just about knowing your role and knowing what you don't know. That is the MPs who are very successful and safe in their practice, understand what they know and know the limitations of the role. I'm not a cowboy out here. You know?
I think that's very insightful because I think about, especially when you said about how you introduce yourself and when you have the discussion about getting to know the patient, I wonder if that process in and of itself kind of makes them aware of the life that they have in such a way that, like, if you're thinking about, show me your grandkids, if you're thinking about your grandkids, if you're thinking about your kids, if you're thinking about these day-to-day things that are important to you, but when you come into the clinic, you don't really think about that anymore. But if in that space, thinking about your life and making it something realistic that's worth living for or worth striving to extend it for.
Yeah.
I wonder if that actually plays a role.
I think it helps. And that is part of the model, right? You have a reason to live.
Right.
So we want you to do everything you can do to keep yourself in the healthiest state to be here for these people in your family who you love. I also like to see your family because when you are not 100% adherent, get them on the phone. Because what they will do if something unfortunate happens is say, well, she was going to the Daughters of Charity every 3 months. So I don't know how this happened.
Wow.
Well, what was happening when you were coming every 3 months? Right? So if we have several visits and we're not getting anywhere, there's not much change. Let me talk to your daughter. Let me talk to your spouse. Let me talk to somebody else to get some skin in the game. Okay, this is what's going on. This is what's going on with mom, your mom. This is what, and get somebody else to say, we got to do the right thing.
Right.
You know, it's just involving all of the people who matter, these outside influences who can help change, you know, make a positive change to promote the behaviors that we want. And that is very, very important for preventative screenings. I mean, the meat and potatoes of family practice is prevention. But people, for whatever reason, if nothing's wrong, they don't feel bad, they don't always value those screening things.
Right.
So
that's well said. How much do you think being an NP has changed and since you've been practicing?
It's changed a lot.
Yeah. How so?
Well, the training has changed.
How so?
As I said, when I went, it was all synchronous on campus. You learned on campus, very intense didactic lectures. You learned a lot of information, and then you went to the clinical setting most times with your faculty in their offices. And so there were objectives. There was a person there who not only taught lecture, but who was in charge of the clinical to ensure that you knew how to do everything you were supposed to do. Now it's now a lot of the programs are online, which is fine, right? Because we're professional people, we're working, we're adult learners. Schedule your time, manage it appropriately. But the clinical setting is challenging in that the MP schools don't always assign preceptors. So the students are required to find preceptors. It's, you know, benefits to that and their disadvantages. Benefit, I can find somewhere close to home that works for me. The disadvantage, I could find my friend and assign my hours. Now, would the person really do that? I don't know, but that is
it's a possibility.
It's a possibility. And so what happens is people graduate and they are not as clinically competent, you know, as we would like them to be. And the profession gets the blame, right? Because you get physicians who work with the people who are like, I had a new MP and they didn't know. And you're like, you know, and so you feel like you're carrying that burden on your back. You don't have to, but you feel like you're carrying that burden on your back all day. Which is why
those are your colleagues.
That's your colleagues, right? And everybody needs a learning curve. I mean, a funny thing is when I moved to Memphis, right after I finished MP school, passed my certification exam and couldn't find a job, right? It wasn't very popular. Or if it was popular, nobody wanted anybody new. And so what I did was I literally took this is when they had yellow pages. I took the yellow pages and searched he was my boyfriend at the time. My husband was living in Memphis. Took the yellow pages and just searched family practice offices and I called. Are y'all hiring MPs? Do you use MPs? One person answered, we use MPs, but the one just quit. I said, great, I'm going to come by for a week, volunteer my time. That was me selling myself to this physician. I got hired. So I literally walked in. I said, I told him, you sit at your desk. I'm going to see the patients. I saw them, presented them to him. This is my plan. I got hired.
That's amazing. This is
the only way you could do it back then. I was like, you know, it's a new person. They don't know what they're going to get. Yeah. Some people like new people because they feel like they can mold them and train them their way. And some people don't have the time. And I understand that. You know, Was this the OB-GYN practice? This was actually Dr. Horn's practice, Arthur Horn. So I stayed there for like 2-3 weeks, and I went to OB in Jackson, Tennessee. It was a money thing. But I wound up leaving because Jackson is 70 miles from Memphis. So I was driving there every day.
Wow.
And in Jackson, they had me in 2 satellite clinics, Humboldt, Tennessee, and Bolivar, Tennessee, something. Gotcha. And so I was running these satellite clinics, which was fine. I was a little nervous. I'm fresh out of school, and I'm managing obstetric patients and kind of alone. You can call somebody, but if you're doing a biopsy and you get you're out there alone. Right. So I said, let me go right back to A.E. Horn's office. He gave me my first chance and just stay there. Mm-hmm.
What was, because obstetrics is different from what you initially wanted to do NP for, to become
right.
an NP
My
for.
sister is a gynecologist.
Exactly.
So I was going to I'm like curbside consult right on the phone.
Yeah.
I can do this. They were paying more money. And then the caveat for the OB job was that they were going to let me do a little bit of medicine there too. So manage just chronic diabetics, asthmatics, hypertensives. Because there are these satellite clinics with not many people in these communities to provide care.
Gotcha.
So they were going to allow me to do that with a different collaborator. So I was still going to be able to do that, but have a special niche for obstetric and gynecologic stuff.
So you still got to do kind of that primary preventative care that you are passionate about.
Correct. But then that was too long of a drive, and I realized money isn't everything. You have to be happy, right, and not exhausted. And so I went back to family practice where you can make more of an impact, reach more people.
Mm-hmm. How long were you in Memphis?
I was in Memphis. Yeah, I was in Memphis from 2002 until 2008.
Gotcha.
And then we moved back home when I got pregnant with my son. I needed support because it was just my husband and I in Memphis. My parents were here. His mother was here. I said, we got to go home because we had to work and we just needed some help and support. So we came home.
I was going to ask you about the impact of Katrina, but you had been back.
So, right. I was not in New Orleans for Katrina.
Right.
And let me tell you a funny thing about Katrina and how, I don't know, maybe it was just Memphis or maybe I was out of tune with the news back then. We didn't have kids. It was just us working and living. I knew nothing about the hurricane coming.
Wow.
And I talked to my mother every day on the phone. I don't know why she didn't. And she was at the time like deputy assistant secretary for the state. And so I don't know why it never came up. I found out about it Saturday morning when my sister-in-law said, me and mother are driving to Memphis for the hurricane. And I said, what hurricane? And she said, oh, it's going to be a bad one. Well, that for the weekend, that turned into like a year or two.
Yeah, right.
So that they were in Memphis. So that was my first hearing about it. And then after it hit, the news covered it in Memphis, but we didn't really know much about it. We did move back home. I knew I had to live at home. I was not comfortable living anywhere else.
Right.
I genuinely did not like Memphis. My friends were here. My family was here. But we came back home because they were recruitment money was a lot then too, to get nurses back. He's a police officer. So we had opportunity and the need to return. And what better way to work in service than to service your community? So
yeah. Do you feel like the New Orleans you came back to was different? Did you feel that way? And do you still feel that way?
I do still feel that way. So we grew up in the East, New Orleans East. So that is where my mother lived before Katrina. She might have had one more month on her house note. So we grew up in the East in the 70s. The East was a very, up-and-coming community. It was very thriving. We had our own mall, the Lake Forest Plaza. We had an ice skating rink, Orange Julius, Flaming Bird. We had all these great things in this mall. And so you literally could go to the mall. You didn't have to leave your community. If you wanted fast food, it was there. We had grocery stores. Everything was there in our community. It was great. The community did start to change right before Katrina. For whatever reason, the community had begun to change. And then when Katrina happened and it kind of leveled the East with the flood, it was a significant change. A lot of people left the community to go to Houston, to relocate to other parts of the country. And my mother moved to the West Bank. She was just too hurt and crushed. She lost everything there because you didn't evacuate to think you would come back to nothing.
Right.
And so she just could not see herself back in that house. And so she sold it and moved and bought a new house on the West Bank. And you're thinking, you're in your retirement age and you got to start over. But that is what happened. Right.
That's a lot. And we were talking a little bit about this prior to, we started, but you mentioned that you guys had started the first NP residency.
Correct.
Yeah,
so
tell
at
me about
DePaul.
that.
So
Yeah.
I say Daughters of Charity. So Daughters of Charity is what we are formerly called. We are actually DePaul Community Health Centers. We are a member of Ascension Health, which is the largest Catholic healthcare organization in the country. I feel like that was a plug for Ascension. So we are DePaul. We have like 12 clinics, like Jefferson Cleaners, one near you. And we started a NP residency, an FNP residency program. First in Louisiana, that is a family residency program. We took our first cohort in 2023. It is a 12-month program for newly graduated family nurse practitioners. They are fully licensed, fully credentialed. And it is just a way to get them some additional didactic content to fortify or enhance their learning, clinical practice with mentored clinics, precepted clinics, specialty clinics, just so that we can get them to be well-rounded, safe, competent practitioners.
You mentioned newly graduated. So is it really just for
less than 2 years out?
Why is that?
We find that, so one reason is that was the grant. That's the rule of the grant. So that's the biggest reason.
Gotcha.
And I would think that is because beyond 2 years, if a person hasn't been hired, then that might be okay. But beyond 2 years, a lot of what you've learned in school, if you haven't been applying it to practice, sometimes it's a little bit more intense. We'd have to be more intentional and purposeful about trying to get you where we need you to be, because it's only 12 months.
Gotcha.
So we have to do a lot fast. You know, we're ramping schedules up fast. We're just enhancing things that you already have.
Right.
You know, and generally we base it on what we have liked in school, like EKG workshops, suturing workshops, joint injection, musculoskeletal exams, things that are areas that we feel our MPs are weaker in. You know, the exams you need to do to keep from ordering all of these
tests.
Thank you. Yeah. You know, save some costs in the system.
What's been the most, I'm trying to see what's the best word for it. What's been the most rewarding aspect of your care that you've, in your experience, the most rewarding? And on the other side, what part of your practice, or what part of what you've been doing for the last several years would you change and wish was different?
So I would say the most rewarding aspect is just seeing people who you saw on day one, poorly controlled diabetic, uncontrolled hypertensive, morbidly obese, come back at goal on A1C. Blood pressures go. They've lost 30 pounds. They have buy-in. They're motivated. They're happy. They feel better. They're thanking you for making the connection. They're referring their family members to you. So you have families of patients who come to see you now because they feel that connection with you. They'll come in and they'll say, "You like family." They you can't receive gifts, but they want to give you Christmas gifts and all of these gifts because they genuinely feel, and they are a part of my healthcare family, right? I am there for them.
Right.
And they are the reason that I go to work every day. So that is the most rewarding part. When you walk in the room and they are so happy to see you, they're not angry with you when you give them tough love. This is not good. I told you last time about this, so it is wonderful when you see that. I would say the hardest part, I think the question was the hardest part. The hardest part is when it doesn't work out in time. And so you see people and you tell them things and you're giving them time to get to where you are. Like, very annoying for my referral team, very annoying for my person who schedules tests, but I'm going to hit you with a mammogram order every time until you do it. Okay, it's annoying for them because you got 20 mammogram orders. They're not going. Eventually, they're going to go.
Right.
And so I want to do it. But what's frustrating and what's disappointing and what is the hardest part of the job is that when they finally go, something's there. And you're just like, you can't say if you would have went a year ago when I told you, if you'd have went 2 years ago, if you'd have just made the appointment with the gynecologist when I told you. Like you would have still had the diagnosis, but perhaps the trajectory of your life right now would be different. The prognosis would be different. And so I can't change that path once so much time has passed and there is a delay. The other hard part is the system. So we have all of ththese clinics. I said we have like 12 clinics. Medicaid expansion, people have insurance because DePaul is largely uninsured, or underinsured, or no insured, right? Or Medicaid, something. We do take all insurances though, but sometimes the issue is that people can't benefit from the access, which is frustrating. So we have the clinics, we have expansion. People have a way to come to us. We send them for a test. We find something wrong. Now you need to see the specialist and there's no appointment until November. There's no appointment until January of 2025. So you have access to me. We have identified the problem, but you cannot benefit from this access. And so that is really, really a challenge. And then you're on the phone just calling people. If there's a cancellation, do this, do that. And so some of the patients, unfortunately, are traveling to Houma and different places because they can get in sooner. The issue with that is that works while you have money for the gas and the transportation to get there. So you might go one time and have a follow-up, but if your transportation isn't there, it just leads to gaps in care. And so you will see the person, because they're coming to you because you're right on the corner. You're in their neighborhood, their zip code. And nothing has changed because you didn't do any of the things that needed to be done from the time I saw you before. Not that you didn't want to. Some people genuinely want to, but they can't. They cannot. They can't. And so that is very, very hard too.
There's a lot of conversations, a lot of talk and discussions about we kind of broached the topic briefly at the beginning, the scope of practice for NPs. And scope creep is something I've heard about. What do you think of that, or what's driving that? And it feels like it's like a professional relationship kind of mismatch between, say, your physicians and NPs. What do you think can help mitigate that, and what do you think is causing that in the first place?
I think the cause primarily is, I don't know if it's nurse practitioners or physicians, but for whatever reason, the left side thinks the right side is in competition as opposed to being in collaboration. Like, I'm not trying to step on your toes. You're not trying to step on mine. We each have a lane. And as long as everybody understands what lane they're supposed to stay in, if you want to come in my lane, put your blinker on and I'll see if I let you over. Likewise, you do the same for me. That's how I look at it. And I think a large part of that is when you get hired at a job, you have to identify and set those boundaries and set that relationship up immediately. When I got hired at DePaul in 2008, they were not big on, they had nurse practitioners, but the nurse practitioners that they used, the capacity that they used them in was chronic care management and group visits. So they would do group diabetes visits, asthma, hypertensive, poorly controlled. That is who the nurse practitioner would manage.
Gotcha.
Okay, that's not what I was doing in Memphis. My last job in Memphis was with this physician who taught me a lot of things. We would round on patients with him, and eventually he turned us loose to round. Okay, all to make him money, granted, but but we learned a lot in the process. He had a stress test in the office, X-ray, ultrasound. He taught us how to look at these things. These are things we didn't get in school, and so he taught us a lot. You do this, you do this. His practice structure was that he saw all Medicare patients first. He did all the initial visits on Medicare patients. We could see commercial and Medicaid patients first, but we had to see them twice, and then he'd see them the third visit.
Gotcha.
And so that was the way. This was back when I finished. Your physician had to sign your charts off and review them. That was the law. The states had different laws, but that was Tennessee and that was Louisiana. And so since then, they don't have to review charts, at least in Louisiana anymore. But when I came to DePaul in 2008 and I saw how they were using practitioners, I said, I'm used to having a schedule. Like, I had a schedule. I know who is too complex for me, and I'm going to send them to you. Like, I'm never going to do what I'm not trained to do. I know my limitations. And so if you know your limitations and your collaborator trusts that you know, then there's generally no issue. And so my collaborator is wonderful. When I started working, and the first thing is they have to learn you. They have to begin, they have to trust that you know. And so the first few months can either be incredibly great or it doesn't work. And so you have to understand that they don't know you. And you could have done it for 20 years. If it's a new job, they have to learn you. And so I understand that. And so I didn't come to DePaul as a novice NP. I had some experience at the time, but I still knew that this physician does not know me. And so when I would do things, he would ask questions, I would just answer the question. And so we would have a relationship, and he would say sometimes, a different way to do it. And it's their approach. A different way to do it would be to do this. This is another option. Or sometimes when he was reviewing my charts, I'd come to work and I'd have an article, some evidence, clinical guideline. And I said, I guess he thinks I should have treated this, which is fine. That might have gone on for a year. And then when he was confident with me, it was done. And that is totally fine. And now he knows I'm going to call you. I will still call. I've been doing it for 22 years. And I will say something is going on in this room because, nursing is a feeling. We can't always. And so I'll say, it does not feel right. I don't know, like the blood pressure is good. This is good, but I have a feeling about it. And he will come in a room and his medical thing will say, this is what it is. Order this, which is fine. And we have that kind of relationship because I don't want to order a million tests that a person doesn't need because I feel bad about it. I really want somebody to back me up and he'll say it's nothing or he'll say it's something. Likewise, I am not the type of nurse practitioner that invokes my collaborator's name in my notes all the time because at the end, some people will say, Dr. So-and-so called in the room. He said this, so this is what it is. So if something goes wrong, it's his fault. No, it's not because you didn't have to follow that recommendation. So I'm never going to invoke your name because you can give me guidance and it's generally good guidance. Right. But if I don't think it's what needs to be done and I still do it, how is that your fault?
Right. Right.
So I think it's just getting the relationship and the scope of practice for NPs is what I tell my NP students, the residents, what were you trained and what are you competent and comfortable to do? To this day, there are certain, I don't suture people. I don't inject joints. Yeah. I've done it before in school. I was trained, but that is not like my meat and potatoes is diabetes, blood pressure, chronic care management. And that is where I am going to stay in my lane. And when somebody is in my room that says I need a joint injection, not from me today. Right. When somebody's in my room with a big abscess that's screaming I&D me, not with me, you're not. And so I'm not going to cowboy it because you are a human with real consequences if I mess this up. And I think that is where a lot of NPs go wrong. They just don't want people to know that I don't do that. I don't give a I don't do it. I can't do it. I'm not doing it. It's fine.
Are there throughout NP training are there physician proctors outside of the?
Yeah, so you can get when you are doing clinical for NP, you can use a nurse practitioner, you can use a physician, you can use whoever will have you. Whoever will have you. Now, again, because I went to school back in 2002 when my clinical faculty was our preceptor, all my preceptors were nurse practitioners. So they were all nurse practitioners. I learned a lot at Loyola. They did a wonderful job with me, but I got a lot of my training on the job from my physician collaborators, which was fine, which was I'm very appreciative of those people who were willing to help me.
I think most people would say that too. I'm saying most physicians would say that too in terms of outside of medical school and, you do residency, you do fellowship. You learn on the job. I've always felt that, not always, I think as I've grown, I've felt that medicine is an experience-based practice. And it's ever changing, ever learning kind of process. And I've always felt that the more you do is the more you'll know. And
that's right.
You just have to do it. And sometimes most times patient doesn't fit the book.
That's right.
And you won't know that until you see patients that don't fit the book, which is most patients. I'll make that case.
That's it.
Yeah.
Everything is not textbook.
Yeah.
And so sometimes that is when I have to call my physician collaborator. Like, I'm thinking it's this because this is what I learned in school. This is A, B, C, D, but it does not feel right. And then he can come in and he'll say, you're right, it is this, And so that is just a good working relationship. And my collaborator and I, we can have dinner with family. It's just, we've been together for 22 years now. So it's just a great relationship. And I think that is what NPs need to, that probably would be my message to NPs. Instead of bouncing around, find a spot and stay in it. Build your practice. Let your patients learn you. You learn them. I've had patients I've been seeing since they were 21 and they are still coming to me. I have my oldest patient and it's so funny. She is 101.
Wow.
She is 101 and she came maybe the week before her birthday and something was wrong with her foot. And I was like, I am not tweaking this medicine and let her not make this birthday. We are going to just do some very, very non-pharmacologic mild things for this foot. 101 is old Arthur talking to you a lot in this foot. But yeah, and so I've been taking care of her since I started there. That's amazing. And so, yeah, doesn't mean I'm doing everything right, but I guess I'm just, it's working.
Yeah. What's your typical day-to-day like?
So on Mondays, I work with the nurse practitioner residents. And so today is their mentored clinic day.
Gotcha.
And so mentored clinic means that I do not have a schedule. The patients are on, there's 2 residents in the Metairie office. The patients are on their schedule. They see the patients, present them to us. We go through differentials, the plan, anything they don't know about, they look it up. It's just really focused, intentional work with them to take care of the patient.
Those,
That's right.
Skills.
That's right. And that's a Monday, and that's from 8 to 5. Tuesday, I'm in clinic by myself all day. That's the busiest day, 8 to about 5:30. Wednesday, I'm with the residents again in the morning with a precepted clinic. Wednesday afternoons, I go to Southern University at New Orleans to teach nursing. I teach health assessment to undergrad nursing students. Thursday, I am in the clinic from 9 to 1 or so, and then I have some admin time, do stuff with the residents. Try to make connections, stuff like that. And then on Fridays in the clinic for their mentored clinic for 8 to 2 p.m.
What are your outside work hobbies? What do you enjoy to do? Traveling?
We enjoy traveling. Of course, spending time with the kids. I love to eat. So we enjoy dining at different restaurants all the time. So traveling and dining are my 2 favorite things to eat. And we typically travel with my sister and her spouse, or we do family vacations.
What's the most memorable place that you've been to? Like the place you just thought of just now?
Turks and Caicos.
Really?
So that was several years ago. And the reason why it was the best vacation is because we literally did nothing. Sometimes you go on vacation and you're going here and you've never been to Europe, so you got to go to the Vatican. You got to you're busy. That's not really a vacation. You need a vacation after vacation. That's not rest. You're going here, you got to do this. But when we went to Turks, we had a home. We rented a home because it was my family, my sister's family, my parents. So we had a home, the pool. The kids were much younger. My sister has 2 daughters. And we literally made groceries. My father cooked the food. The men would grill. We'd hang out in the pool. We did nothing. We did not leave the house. You would think you didn't get in the water. Nope, we saw it from the pool. But that was very relaxing. And we played card games. We engaged and interacted with each other.
Right,
I think that is what made it fun.
Right.
Family style meals, eating together, breakfast, lunch, and dinner. The cousins get to play. It was just a good time.
Where are you most looking forward to going next?
Going next, where do I want to go? We do have a trip planned to Kentucky for my brother-in-law's 50th birthday in May. So that'll be fun because that is a bunch of couples going to that. But let me think of a place that I have not gone that I would love to go. I really don't, because we've been to a lot of places. Perhaps Athens.
Greece. My mom wants to go to Greece. I don't think she's gone yet, but it's definitely one of the places that it's on, and she travels quite a bit.
Okay.
She loves to travel.
Yeah, I think that would be, but that's not a vacation.
Yeah.
That is an excursion, educational, let me see all the things I can see type trips,
That's an interesting point, because vacation and that can be conflated quite a bit, because we conflate vacation and, because if you go to these places, the idea is that you go to do things in these places. Whereas I guess vacation is really meant to be restful.
Rest. That is you detach. Mm-hmm. You are with the person you are with, the people you are with, and you vacation.
Right.
You have a good time. And you can vacation, and then when we travel out of the country, we generally take the kids, unless it's some adults trip, because they need the experiences too. We try to give them the experiences too. And so you have to navigate that. My kids are older now. They can kind of fend for themselves, fortunately. But, vacation to those types of places is work.
If you couldn't be a provider and if you couldn't be a provider or an educator, because I know that's probably second, what would you do?
I would be a guidance counselor. I would be a mentor, a guidance counselor. So I have there's this running joke that I have in the office. I'm always referencing old television shows, the Jeffersons, Weezy and Helen. They worked at the help center. Yeah. I would love to start a help center. And I would just have that center. I had a name for it. And I would just develop this center, and it could be resume writing, GED branch, help people sign up for benefits, help them get insurance, just a help center to help the people in the community access the resources. You'd be surprised how many people do not know the things that are available to them because nobody's told them. They don't have the resources, to access these things. So I would love to just run a help center. If I win the lottery, look for a help center with my name on it.
Do you feel like you need to, obviously you don't have the time, you have so much of your hours are kind of taken up anyway. What would it take for you to do that? Money.
I have the drive. I have the idea. Strangely enough, there was a grant that was, I don't know if it was a grant. I don't know if it was the Obama Foundation, some foundation. I sent in a video, pitched this idea. Of course, I didn't get picked. It was just a kind of last minute one night thing. I did it. But if I had the funding, like I always say, if I won the lottery, I would take care of a lot of people that I know. But I would also have to do some good with the money and invest and develop a help center. I would love for DePaul, I say that all the time, to do some kind of community resource center. I'm sure there is something like that already in existence here. Right. I know there's the website where you can find all of these resources, Aunt Bertha, Big Bertha, something like that. But I would love to just have a center where people can come. And even if it's just daycare, bring your child here. We'll figure out a way. You don't have to pay for it. But a lot of people can't work, don't work. They don't have childcare. And we assume that they don't want to work or they're lazy. Well, that is not the case. If I have to get a job that pays $15 an hour, but the nursery essentially runs me $30 an hour, right. I'm going to stay home. It's you in a hole. Wash. Yeah, and I think it's all perception. I'm big on perception, and you have to consider another person's perspective. Have you ever heard of this book, Shadows of the Neanderthal?
No.
So it's a very small, it's Shadows of the Neanderthal. It's not a long book at all, but it's basically about cave people. Mm-hmm. And the cave people have lived in this cave for a very long time. And one person in the cave wants to go against the grain, and he says, I'm going out. You can't go out because there's spooky stuff out there. He was like, I'm going out the cave. I want to see. He travels out, and they shunned him. They were like, you never come back because you're doing something different. Change is different and hard for people. So he goes out, he finds a man on a hill, and he finds another man who I think was exiled from his cave or something. And so they're talking to the man on the hill, and, some kind of way, the man says, you go to the east to figure out what you need to survive, and you go to the west to figure out what you need to survive, then come back. Well, this guy might have said, I need a basket. And this guy says, I need a bow and arrow. And so then they argue, you don't need this, you don't need that. And so the old man says, let's go over here and look. Well, the man who said he needed a basket had a field of grain and fruit and vegetables. Mm-hmm. The man who said he needed the bow and arrow had cattle and cow. And so the old man's point was always consider another person's perspective before you say they are wrong or start to argue. So I always try to see, okay, you're saying that, let me just step out of myself and see what are you experiencing on your side that can make you feel this way. Instead of me trying to shove my thought down your throat, let me consider where you're coming from. And once you do that, then you can understand why a person feels the way they feel. And then you can have a purposeful conversation about how to make the change that you both generally want to make, but you don't know how to get there because you're arguing.
Because you're both on the same side.
That's right.
And sometimes it can feel like you're not, but you're really on the same side. You're both trying to get to the same end goal.
That's right.
Because most people aren't trying to be malicious or
difficult for the sake of being difficult.
Yeah, most people aren't. And I think the biggest challenge with healthcare, where that is concerned, is certainly taking the time to dive deep into those issues and those challenges, especially the ones that have been internalized by our patients.
That's right.
I have to always, remind myself that they are, by showing up, kind of like what you spoke about, by showing up, they're making themselves vulnerable. Mm-hmm. And it perhaps isn't my place to kind of rub it in. It's not the time or the place to rub it in.
That's right.
Yeah.
It's just a time to listen to what they're saying, to receive what they're saying, mm-hmm. and just, welcome them and receive them where they are. Because if they don't like the interaction, they're not coming back.
Right.
And then you've lost them. right? People want to be talked to, not talked at. And so that's just something I believe and I try. I'm not always the best communicator. Don't get me wrong. I'm not like an animal whisperer or something. You have periods of frustration where you feel like I've said the same thing over and over and over again. One of the other nurse practitioners who works in the office with me, we have this funny thing. I'll see somebody on the schedule and I'll say, okay, they're back. And I'm looking at the numbers. Blood pressure is still high. A1C is still not at goal. And so, I'm just going through the things in my mind. What am I going to do? And she always tells me, she said, you're going to touch the doorknob and you're going to say, I only want the best outcome from this patient. You're going to take a deep breath and walk in the room and do the visit. And so that is what I try to do.
That's great advice. Mm-hmm. You're one of 3, 4?
So in the Metairie location, so again, we have 12 clinics. In the Metairie location, it's 1 physician, 3 nurse practitioners. Every clinic has a different physician NP ratio. So I am the lead nurse practitioner at DePaul. And so we probably have 10, 15 or more because we have psych NPs, we have NPs in the school. As far as family NPs, those are the ones that I'm most in contact with.
How many different, because now that I'm thinking about it, are there different, there are different avenues that you can embark on as a nurse practitioner?
Yes. So you can do family, women's health, psychiatric NP, acute care NP, pediatric NP. Right. Family typically is for a person who doesn't know yet. It's wide, right? Not deep, but wide, right? You see a specialist for deep. Right. And so the family is adults, pediatrics, obstetrics, gynecology, and geriatrics. But you can be a geriatric NP. There's gerontology. There are different paths for whatever your passion is. But a lot of people do family, and then they just figure out which place they want to be in.
And are those individually different kinds of training?
Yes.
So if you wanted to be an acute care NP?
Yes, they are training in the hospital.
Got you. So that's a very different setup from FNP.
They are typically working with, critical care people. They can do whatever the hospital allows them to do. A good friend of mine is the lead acute care NP at Emory Hospital in Atlanta. Mm-hmm. And he finished as an NP, an FNP, but he went back to school for acute care.
So you'd have to go back.
You got to go back.
Oh, wow.
And get another certification, take another exam.
Wow. Okay. Mm-hmm. So
because it's that different. The train, because he's got to do central line. He's got to do a particular
set of skills.
That's right. Gotcha. That's right. And so you go back. Like at one point I said I was going to go back and get a women's health certification while I was getting my doctorate. I really had enrolled to do both, women's health and the doctorate. I did the doctorate first and was like, I am tired. I am done. I'm doing all of the women's health stuff I'm going to do. I don't need this additional thing. I don't know that I regret that decision. I don't know if that was a good decision, but you have to go back.
Did you feel like you needed a doctorate
to teach?
To teach. So that's really the biggest benefit is if you want to do academia.
It's academia because you are not a doctor in clinical practice. And this is where I get a little bit of resistance from my NP colleagues. I feel like it is... I don't want to say not fair. I feel like it is misleading. Now, don't get me wrong. Patients, you can tell them 100 times you're an NP. They can see your credentials. They're going to come in the room and say, hey, doc. They're going to see you in public and say, hey, doc. But my job is to tell you I'm not. Now, I might not say it every time, but, my badge says NP. Your prescriptions say NP. And so you're like, why do you keep saying it? But that is just, and some will say, you're my doctor. You're the doctor to me, But so I'm not going to I introduce myself as Krystal, right? That is who I am. What do I call you, Krystal? It's fine. Some people say, well, I'll call you Nurse Krystal, whatever makes you comfortable. But I am fine that way. Right. That is in the clinic setting because I don't want you to confuse me for being anything I'm not. Like I am comfortable where I went to school, what I chose to do. We are fine with that. My check, in addition, says otherwise. It says I'm an NP, right? So there's that. But when I am in academia, I am Dr. Henry. And that my students call me that. So that is why I went for that. When I went back to school for the doctorate, it was pretty clear at DePaul that there was no payment adjustment for that. That is something you want to do, which is fine. But I did it more because you can teach in nursing school with a master's on the undergrad level. But to teach grad school, you need a doctorate.
Got you. Why did you want to do that?
Because I wanted to educate the next generation of nurses. So what happens is you have sick relatives, you have sick family members, and you go in and you see stuff. Not to say that the nurses are bad. I'm not saying that. I believe nurses are doing the best they can with what they have been given. And so a lot of programs are hybrid. They are online. It's different. And so nursing is it's a task. You know what I'm saying? It is that. So you have the knowledge. A baccalaureate nurse has the knowledge. I know I'm doing this because, as opposed to an LV and an LPN who is just doing the task. They might not have the rationale behind it, but it is a lot of just doing things, right? And so if you don't get that kind of synchronous learning that historically was given to nursing students in nursing school, you may come out of nursing school with a license, you've passed boards, but you really didn't put any of this stuff into practice. You got all of this evidence you learned, and now we got to start practicing on real people. And so you'll see nurses who come out and they're sticking and missing a vein, or they're doing this, and it's not a big deal about it if you're not the one getting stuck. But you just feel like, let me go out and give back and do some things to improve the profession that I am genuinely passionate about. Right. I feel like nurses get a bad rap. I don't know if I've said that 20 times or not, but half of it is because there are so many avenues you can go for a nurse. LPN, RN with a diploma, RN with a bachelor's. Now you got 30,000 NPs. Some are hybrid, some are all online. It's so much, and so we're all over everywhere.
But everybody's a nurse.
Everybody's a nurse. And are you a nurse because you want to be a nurse, or you think it's a big payday? It's not really a big payday anymore. Price is relative, but and so I just want to get nurses to know that it is truly a caring profession, and we want people in the profession who genuinely care about the health of individuals and, in the broader sense, the community. And so that is what I try to impart on my students. You are doing this not for a paycheck. You don't want to graduate and go buy a Benz or a Range Rover. You want to save your money. You want to work. You want to improve. And then after you work a few years, if you want to go back to school, do that. But it is truly a caring profession. And if you do it the right way, can be physically, emotionally challenging. It really can, because you connect with your patients. And so when things happen, if they have a terminal illness, that is hard, especially in my role now where I've been with them so long. And, your first thought is, what could I have done differently? And sometimes there's nothing you could have done differently, but you still feel like,
that responsibility. Once they show up, you feel like that responsibility
that is yours. Yeah. And you can do everything right, but you're going to go through that chart and say, well, what did I do? And some things are just, there's nothing you could have done differently. Everything was done right. It is just
out of your control.
It's out of your control how the chips fall.
Your sister, older, younger?
She's older. We are 21 months apart.
Gotcha.
And she is in Charlotte, North Carolina.
Gynecologist,
Kelly Rouse. And her husband is a retinal surgeon.
Oh, wow.
Yeah. So they met in med school over at Emory. So, yeah.
What did she play a role in or an influence in you wanting to be a nurse?
I always wanted to be a nurse. It's just something before I even knew what she wanted to be. She initially was going to pharmacy school at Xavier. She went to Xavier. I went to Dillard. We both went on full scholarships. But she was going to pharmacy school. And I believe what happened when she was in pharmacy school, she was like, I'm taking all these chemistries. I'm passing them with A's, just like these pre-med students.
I might as well.
And she genuinely wants to help people as well. And so then she just changed her major to pre-med and went on to medical school. Yeah. Did a residency up in Chicago, and now they're in Charlotte.
Do y'all have a competitive spirit between you?
We do not.
No?
We do not have. There's no competition. We are best friends. We talk every day on the phone. Probably annoying to maybe her family because we talk on the phone all day, all night, just calling and talking. I don't even know what we find to talk about, but we find something to talk about on the phone. We didn't grow up arguing. My mother would not have that. If there was a toy we argued about, she would throw it out the door. Nobody can have it. So that is not anything that we grew up doing. And so it has never been a competition. She is one of my biggest supporters. She always tells me I don't give myself enough credit. And I am one of her biggest supporters too.
You may have said this earlier, is your mom an educator as well?
My mother is a social worker.
Social worker. That's right.
She's a social worker.
Right.
She went to Loyola, New Orleans, did not enjoy, she had a good time there. I don't want to say she did not enjoy her time. She went at a time when there was a lot of racial tension, right? And so she went there, and then she went to Southern New Orleans for her master's in social work. So she's a social worker.
I bet she has some stories.
She has some stories, and she will talk your ear off if you want to hear her stories. She has a lot of stories about her time at Loyola, and she would have to, I guess this was before typewriters, I don't know, but they were writing papers, and she would have to write several copies because the professors would throw them away, and she'd say, here's another.
Wow.
Here's another.
Wow. Yeah, I'd certainly love to
yeah, maybe she'll be next.
I know. We'll get her on. Get her on.
Yeah.
Well, thank you so much. This has been very enlightening. Thanks for taking the time.
Well, thank you for having me.
Absolutely. Any closing thoughts that you'd like to share?
Help Center coming near you one day.
I will be looking forward to it. With your name on it.
With my name on it. Yeah.
Thank you so much.
Thank you.
All right. Hey guys, thank you so much for watching this episode of The Last Zebra. As always, please don't forget to like, subscribe, comment, and share. We have new episodes every Monday morning on all of your favorite podcast platforms, and new episodes show up on YouTube on Tuesday mornings. Looking forward to seeing you guys on the next one.